Let's talk about why someone develops androgenetic alopecia.
The reason somebody develops androgenetic alopecia is hidden in the name itself. Let's not forget things like lifestyle. So if you're a heavy smoker, very obese, unhealthy, unfit, that's certainly going to put a lot of physiological stress on the body, and that's going to accelerate the balding process.
Hair loss impacts both men and women, but there's a lot of confusion as to what hair loss medication you should use. Together, we're going to explore two FDA-approved medications, Finasteride and Minoxidil. Now, my name is Dr. Ross Kopelman. I'm a hair restoration surgeon out of New York City. And joining me today are my two co-hosts, Dr. Asi Peretz and Dr. Eric Peretz. Both are from South Africa, and they now have practices in Israel as well as in Greece. This is the first episode of the Hair Doctors Podcast, and we're so excited for you to join us. Why don't we kick this off and let's talk about the meat and potatoes of this episode, which is about androgenetic alopecia and what are some of the most common treatment options that we kind of utilize in our offices. And you guys might use different regimens than we do here in New York City. But I think to start the conversation, let's talk about why someone develops androgenetic alopecia.
The reason somebody develops androgenetic alopecia is hidden in the name itself. So andro means male sex hormones, so things like testosterone, dihydrotestosterone, and genetic means your genetics. So you're not going to get it if you're not genetically prone to get it. And if you have very low androgens, which is very uncommon, but if you have very low androgens, then you're also not going to get this hair loss. So it's an interplay between genetics and male sex hormones, chiefly being dihydrotestosterone or DHT.
Yeah, but one thing that's vitally important to emphasize is that women also get androgenetic alopecia as well. So this is not solely only for men in terms of its major impact.
Yeah, absolutely. Absolutely correct.
And Asi, do you know how they figured this out?
If I'm not mistaken, back in the middle, I want to say it was, I don't know, I'm not going to give an exact time frame, but eunuchs, so people that got castrated at a very young age, they used to use these people to sing at certain operas and maintain like a very youthful voice. So they would castrate them at a young age, and they realized that all these people that were castrated never developed any balding. And that's when they realized that it must be something to do with the testes. What did the testes produce? A whole lot of male sex hormones.
Now, it's important to emphasize where that dihydrotestosterone has its biggest impact, because the hair in the back of our scalp, okay, is less sensitive to this hormone, DHT. But the hair in the front, when you typically think of a male, we're going to talk about men first. When you typically think about men where they have hair loss, it could be pretty extensive. And that's because this hair is more sensitive to DHT. For women, that happens in the hairline, okay? Sometimes they can get some temporal recession, and sometimes they can get thinning of their part. So there's certain areas on a female hairline or hair or scalp that are more sensitive to this hormone, DHT, and that can cause female androgenetic alopecia.
Females generally retain parts of their frontal hairline. They can get recessions, like you said, but then they lose this middle parting. So the middle parting can sort of widen, and that's referred to, and you look at the Ludwig scale generally for females to see their level of hair loss.
Yeah, and that extends all the way back, and that's why a lot of instances it's harder to transplant females because they have more unstable donor areas. It's harder to know which hairs are going to be genetically prone and which hairs are not. Harder than in males typically.
So we know genetics, we know DHT plays a role. What are some other potential common factors that could be contributing to hair loss?
Well, I guess I can take this, especially amongst females. I mean, when we talk about hair loss in females, before even doing anything, obviously, if they come for a consultation, you'll do some microscopy, trichoscopy. But if you're going to be thinking about starting them on any sort of treatment, before doing that, we need to test for thyroid functions. We need to test for vitamin D levels. So anything that can cause hair loss, you'd need to do a full blood panel. And I mean, maybe we can put up some notes for this podcast. We can actually recommend some blood tests to get if you're a female and you're experiencing hair loss. I think that'd be a nice thing.
Yeah, and let's not forget things.
Oh, we use the same phrase. Go for it, Asi.
So I was just going to say, and you're probably going to say the same thing, Ross. Let's not forget things like lifestyle. So if you're a heavy smoker, very obese, unhealthy, unfit, that's certainly going to put a lot of physiological stress on the body, and that's going to accelerate the balding process.
I was also going to add hormonal changes.
Of course, yeah.
That's a big one. Or if someone has PCOS, if you're a female, a polycystic ovarian syndrome, these can be contributors to why you get hair loss. And then the last one I was going to throw out there is a condition known as telogen effluvian. And this happens if you've had a stressful moment in your life in the past 3 months and your hair could kind of just be shedding all over the place. So there's a lot of different causes for hair loss, and I'm sure we're going to spend a lot of time on this podcast talking about that. But let's now kind of dive into what are the medications that are at our disposal as hair surgeons or hair loss doctors, I should say, that can help patients kind of restore some of their hairlines.
So I think typically we use Finasteride in androgenic alopecia. Finasteride, is my first go-to. A lot of other doctors might say Minoxidil. I think it depends on what level they're at when you first consult them. But yeah, we typically start patients off on a low dose of Finasteride orally. And that's because, a lot of them are very, very nervous about potential side effects. To mitigate any chance of side effects and also to make the patient feel a little bit better and to prevent that nocebo effect, we start them off on a lower dose, about 0.5 milligrams daily, and then we take it from there.
What's a nocebo effect, Eric?
So pretty much you've read all these things on the internet. Now you're worried about having sexual side effects, and by taking this medication, you suddenly have started to experience them. So, what your psyche is telling you might actually cause these side effects.
So it's the opposite of a placebo effect, right?
Exactly.
So a placebo effect would cause a positive outcome, whereas a nocebo effect, you would manifest a negative outcome, but it's more psychologically induced.
So, look, what I think is important to point out is that Eric is emphasizing that DHT blockers, okay, are likely the first line if we're dealing with male patients, okay? And as we discussed earlier, DHT is a major, probably the number one contributor for why we have hair loss. So Finasteride, if you want to take this, go for it. If you walk everyone through how a DHT blocker works, I think that would be beneficial.
So pretty much your body naturally produces testosterone, and it's converted into DHT through an enzyme called 5-alpha reductase. And what Finasteride would do is block 5-alpha reductase so that it cannot convert into DHT. Yeah, and thereby lowering the DHT levels, and so your hair doesn't get burnt off.
Yeah, so pretty much just to delve a little bit deeper to that, for if there's any nerds out there listening to us, which I hope there will be a lot of. So pretty much testosterone essentially has two fates. So it can 5-alpha reduce into dihydrotestosterone, or it can aromatize into estrogen. Now what we do when we treat hair loss is we want to lower systemic DHT. Well, actually, we don't want to lower systemic DHT. We just want to prevent DHT from reaching the hair follicle, and pretty much up till now the only way to do that was lowering systemic DHT. So we block this enzyme, so thereby you get, as Eric said, more testosterone and less dihydrotestosterone in the body. Now when you have more testosterone, sometimes more of it can be converted to estrogen, which could lead to issues as well. But usually you get a very moderate increase in serum testosterone, and patients do extremely well on the medication. I'd say, over 90% of patients who take this medication always say the only side effect they have is an improvement in their hair. But that's not to say that they don't come with side effects as well.
It's worth pointing out that Finasteride is the only FDA-approved DHT blocker, but off-label. In my office, actually, we commonly prescribe Dutasteride, which is a stronger version of Finasteride. So Finasteride blocks this enzyme that you both were alluding to, which is 5-alpha reductase type, I believe it's type 2, right?
Yeah, correct.
Dutasteride blocks 5-alpha reductase type 2 and 5-alpha reductase type 1, and it actually is more effective at blocking the activity of this enzyme than finasteride. So it's about 90% with dutasteride, it's about 65% with finasteride. So we find that patients actually do better with dutasteride in terms of the results, but I know a lot of doctors are not comfortable prescribing this medication off-label for hair loss, but yet it is certainly prescribed to millions of patients, not to the same level as finasteride as a DHT blocker.
Yeah, so Dutasteride for us is like the nuclear weapon, you know. We use it for people who have very aggressive hair loss, especially if they're very young. But typically we like to start patients on Finasteride because it has a much shorter half-life. So the half-life is about 8 hours for finasteride, whereas dutasteride can be about 8 weeks. So if you're experiencing side effects, it's going to last a hell of a lot longer, which is what patients don't want. Generally, we find that people who don't have side effects on the finasteride will not have side effects on the dutasteride, which is great. So that's why we start them off on that finasteride, let them feel comfortable, and then we can up them to the dutasteride if needed.
Yeah, and also, I mean, what if, finasteride after 5 years, if I'm not mistaken, the number is about 65% effective, which means that only about 65% of patients on finasteride after 5 years will still experience a benefit from it. Then we can at least pull out the big guns and say, cool, finasteride has stopped being so effective. Let's put you on dutasteride. But if you start them on dutasteride, 10 years down the line, maybe they stopped getting the desired effect. What you're going to do? You got to up the dose of dutasteride? I don't know. So that's why we always like to start with smaller guns and then bump them up if we have to. But I absolutely agree with you, Ross. I think dutasteride is more effective.
What have you guys been seeing in terms of compliance? If you put a patient on finasteride, do you see that they're routinely taking this on a daily basis?
So yeah, I think it's all about
yeah.
how we educate them, really. If the patient is well educated and well counseled about taking the medication, generally speaking, they are very compliant.
And the cool thing about these 5-alpha reductase inhibitors like dutasteride and finasteride is even though finasteride has a half-life of 8 hours, it still irreversibly blocks that enzyme for up to a month. And that's also on the downside why side effects can last for up to a month. But it also means that if you forget to take your tablet here and there, it's not the end of the world. It's still going to work. And actually we find that even 1 milligram 3 times per week works perfectly well. Typically, that's the dose I start my patients on, 1 milligram 3 times a week.
And
Okay.
Asi and I have recently actually moved a lot of our patients onto topical products. And we find that patients feel more comfortable taking it, but maybe if you want to, Asi, you can talk a little bit to that.
Yeah, so there's...
Wait. Before we get there, let's talk about these side effects that you're referring to. You're talking about systemic side effects.
Yes.
I'm assuming around erectile dysfunction, inner
Libido.
groin pain, testicular pain, libido. I do want to preface one thing, though. There was a study that looked at a group that was warned about side effects and a group that was not warned about side effects. And the group that was warned about side effects reported a higher incidence rate of having erectile dysfunction.
That nocebo effect.
There certainly is some psychological thing going on with the finasteride. But I'll tell you, I was taking finasteride actually for a short period of time, and I had inner groin pain. And as a result, I can't take finasteride on a daily basis, and I dose it out. Like I'll take 1 or 2 pills a week. I won't take it on a daily basis.
That's exactly
what
I
find
do
everyone has their dose, right? So everyone has a magic number that works for them. So you really have to tailor it with your patients.
Yeah, completely agree.
Yeah, I mean, these side effects are very.
So because of the side effects, you've switched over to using topicals.
So I think that topical firstly eliminates a lot of that nocebo effect. So people are more prone to get this nocebo effect if they're actually taking pills into their body, right? When people put things topically, they don't feel like it's going into their body. It's like putting on a cream. Okay, so I think it mitigates side effects from that perspective. And also there's been studies that actually show less systemic absorption of the drug, of the active ingredient, and less lowering of systemic DHT. Now we can, and maybe this is for another episode, we can go into all the topicals, because not all topicals are made equal. And actually, I'm going to be interviewing one of the founders and CEOs of what I believe is one of the most leading topical products on the market. But certainly, I think topicals have less side effects. But on the flip side, they could potentially also be less effective. For a lot of times we don't really use finasteride always to grow people's hair back. Sometimes we use it as a prelude to surgery. In other words, we want you to prime your donor area. We want the donor area to grow and become more robust from the medication. And if you're doing a topical, well, then you're going to have to spread it all over your head. It's not as convenient, let's say, to use for all cases. I think just going back to the side effects, I think people are very interested in this. I mean, it's a huge topic, side effects of finasteride. So as you mentioned, inner groin pain, testicular pain can certainly be, I've heard a lot of that. Typically it goes away after a week or two of use. I find that those minor testicular aches go away. To be honest, I'm not 100% sure the physiology behind that either, but I have seen it reported in quite a few of my patients. And then you get your sexual side effects, which is, your low libido, which no one wants to hear that. People are like, Doc, I'd rather be bald, and erectile dysfunction. Also, it goes hand in hand with that low libido. So, and then
I gotta be honest with you. When I start, I don't know if you guys take DHT blockers. Do you guys take DHT blockers?
I do, yes.
I don't.
So Asi, between you and me, when you started to take the pill, right before you started, did you have that little fear, okay, something's gonna happen? I mean,
yes.
I did.
Yes,
nothing happened. I mean,
yes, I did.
But I think that's a natural thing to just have that fear.
I actually found for myself, at a higher dose, I was getting sexual side effects. But the thing with sexual side effects, maybe I'll find this study for another time. Sexual side effects are the most subjective side effects that there is, right? So men rarely have. There was a study that was done that shows that men have zero gauge on their sexual performance, right? It's very hard to gauge. And, sometimes a little bit of stress will give you the same sort of outcome as you don't know what it is. Is it the finasteride, the stress?
You bring up a very good point, which is actually sometimes when patients start to take finasteride, it was I don't know if that's the right word, but they had erectile dysfunction to start, and it kind of revealed itself when they started.
Yes, exactly.
I'm sure Asi always overrates his sexual performance.
Okay.
By the way, the moustache is November. It's only for November, guys.
With myself, I found that honestly, when I lowered the dose, the side effects went away. So yeah, look, they're very real, but it's the only thing we have rarely that treats the root cause of balding. That treats either you got to fix the genetics, right? Which maybe someday we'll be able to do with CRISPR technology or something like that. But the other way is to fix the andro part of it. And today we're kind of using a baseball bat by lowering the entire systemic DHT, but we really hope that some treatments will be more targeted, therefore less side effects.
Yeah, and I'm sure we can talk about androgen blockers in another podcast, because it does get quite in detail, and I have a lot of patients interested in it. But, they're finding the stuff in Russia and then compounding it themselves, and it's, definitely not FDA approved yet. Yes.
58841, is it?
Yeah. But
now, wait, before we switch gears on DHT blockers and get to the next medication, we should preface that DHT blockers are really reserved for men and for women who are postmenopausal. I personally do not feel comfortable putting any women on a DHT blocker if they're premenopausal, if they're well, you can be premenopausal, but if you are thinking about getting pregnant, if you're breastfeeding, you're currently pregnant, absolutely not. If you're finished delivering kids, and if you're completely done, and you're not in menopause yet, I'd feel comfortable putting you on a DHT.
And I also think it's it's definitely, it's not my first line of treatment anyway. So I think it would go like minoxidil, spironolactone, and then maybe like a finasteride with a oral contraceptive as well.
Yeah, to make sure they won't get pregnant.
And then I was going to say one thing about men. If you're a male, even though I don't know what your stance is here, but for men, what we do know about DHT blockers is that it does have an impact in lowering sperm count. So my recommendation to all my male patients are, okay, if you're young and you're in your 20s, take it right now. But once you get married and you're a few months away from getting pregnant, stop the DHT blockers and don't resume it until you finish having kids. Because I don't want to play any role in any issues with them having issues with their pregnancy. With that said, there's nothing in the literature to support that this would be a major cause for why someone wouldn't get pregnant, but I like to take every level of precaution.
It's
absolutely.
funny. I get a lot of like big gym bros that they have been using test and anabolic steroids their entire life, and they come to me like concerned about finasteride and fertility. Whereas if you look at something that known to make men infertile, it's actually testosterone. So exogenous testosterone, anabolic steroids, that rarely blocks off sperm production. We know finasteride can lower it slightly, but actually the studies show that it really has no effect on male fertility at all unless you are already hovering above that infertile range. Then it can really push you into, okay, now you can't make children. But even then, they've shown that when you stop the DHT blockers, your function will resume. So if you're worried about it, you can do a sperm analysis and continue. But Ross, you're 100% right. I actually, and this is what Eric's going to say.
We tell people this.
We tell people
the same thing, right? So we say before you're planning, stop the treatment, and then I sometimes tell them to start taking it again once the woman is pregnant. But I stress that they use condoms, even though there is no evidence that it can seep into the sperm. I still stress that they use condoms so that the female has absolutely no exposure to any finasteride.
Yeah. And I'll just say one last thing about side effects that I always warn my patients about is gynecomastia. So gynecomastia can be a side, which is male breast tissue accumulation or man boobies. That can be a side effect of finasteride and dutasteride. And the reason for this, I think, is when that testosterone goes up, because DHT is blocked, so there's more testosterone. Now you might get some extra aromatase activity that aromatizes that testosterone to estrogens, and that can give you the gyno.
Yeah, but the first sign is nipple sensitivity, right? So
exactly.
Yeah, first look out for that first sign.
We usually tell them, look, you're not going to develop gyno overnight. So as Eric said,
it's also a very rare side effect. I mean, I've seen it,
very rare,
but it's very rare. It's not common, and usually this completely resolves on its own once you stop the medication. I think that's something to stress. That if you have any of these, we're talking about side effects because we want you to know that anything you take is going to have a side effect potentially. It doesn't mean it's very common. We don't see these side effects commonly, and when we do see them, they're very treatable, and it really mostly has to do with just stopping the DHT blocker altogether.
Yeah.
So I was going to switch gears and talk about one more medication, unless you have something else to add about finasteride.
I was just going to say about the gyno is I think that if you continue taking it and that gyno continues and formalizes into breast tissue, then you're going to have to get it surgically removed. It's not going to go away if you just stop the medication. But yes, if it's the beginning stages of gynecomastia, you stop the meds and it will resolve. And just to close this off, that's why we always say, guys, it's very rare, but if you ever feel nipple pain sensitivity, you let us know. Or you stop the medication.
Exactly. Yeah, let's talk about something more interesting.
Okay, so I think the last medication we're going to talk about today is another FDA-approved medication. There's really only two in the entire world. There's Finasteride and Minoxidil. And here is the most, I don't know what you guys use in Israel or what you used in Turkey or in Greece, but this is Rogaine, and this is the most popular form, in my opinion, of Minoxidil that we use. So I'm curious to hear what your approach is for this. And by the way, this is a topical Minoxidil, but there's also oral Minoxidil.
Yeah, so typically we would tell our patients to use both finasteride and minoxidil, and the reason is because we find it actually works better when it's used together. I like to start patients off on oral minoxidil because I find it's less cumbersome to use. So instead of applying it twice a day, you just take one tablet and forget about it. And remember, we're using very, very low doses of this oral medication. Incidence of side effects is pretty low. So, I think patients tolerate it really well.
Yeah, I agree with Eric. I think we always recommend using both. And if patients don't want to use finasteride, we certainly recommend minoxidil. It seems that topical works just as well as oral, although some people lack. So remember, minoxidil is something called a prodrug, which means it's not really active on its own. The body has to convert it into minoxidil sulfate for it to actually be biologically active. And some people lack the enzymes. I believe it's sulf1A1 and sulf1A2 or 2A2. I can't remember exactly. But those are the enzymes that you have that activates that minoxidil. And some people don't have those enzymes in high concentration in the skin. So they respond a lot better to the oral medication. In my opinion, I think the oral is way better. It's just easy to do. As Eric says, you take the tablet, forget about it, take one to the next day.
If you don't want to take the tablet, I'd highly recommend the foam because I find the foam is less irritating to the scalp. The drops are probably mixed with propylene glycol, which can make your scalp very, very itchy. And yeah, so if you do have an itchy scalp and you're using minoxidil, try the foam or go oral.
So what's so interesting, so I totally agree about the foam approach. I like this better. A few things when it comes to topical that I think you guys brought up. Number one, compliance is really challenging. To have to apply this every day and not forget and put this part of your routine, like brushing your teeth, is, can be tough. And actually, I have a bottle in almost every bathroom in my home because sometimes I forget. But the other thing, let's talk about topical first before we run off to oral again. This can be used for both men and women. And obviously, if you're pregnant, breastfeeding, you don't want to use any hair loss medications. But women who are not breastfeeding, premenopausal, can use a topical as well as oral. Now, I tell all of my patients, men and women, that they should use 5% foam minoxidil. And on this bottle, this is called men's Rogaine, but there's no reason why a woman can't buy this, okay? There's actually something called the pink tax in the United States where just because the bottle is pink or purple, they charge more, okay? And you get, I think, one less bottle. And actually on this bottle, it says, do not use if you're a woman. Now, this is complete bullshit. If you're a woman, you can use this bottle, okay? And I'll actually show everyone how I apply this. What I do is I shake it up and I put a little foam here, right over here, right like that. And I rub it in. Now, the interesting thing about the foam is, or the liquid, whichever one you end up deciding to use, and by the way, make sure to wash your hands after, because if you touch your beard or your face, you'll grow hair in unwanted places. But what's interesting is on the bottle it says use twice a day. And I don't know what you tell your patients, but I say once a day is more than efficient because this has an 18-hour half-life. And
Agreed.
Twice a day, it's really tough to apply this twice a day.
The studies have been done on twice a day for men and shown good results, and once a day for women and have shown good results. So, if they can do twice a day, fantastic, go for it. That's what I tell them. If they do once a day, that's okay. But if you're not going to be consistent with it, I literally tell them that rather you don't take it because otherwise they'll have shedding.
Yes, so yeah, that's important. When you start minoxidil for the first 6 weeks or so, you can have an increase in hair shedding. So you don't want to...
It does not happen to every patient that I put on
That's
minoxidil.
True. Correct, agreed. But it can happen. And also, Russ, I would say about the women and 2%, the 5%, I think that sometimes there is sometimes it can be prudent to start women on 2%. And I know, and I agree that 5% is a therapeutic dose, but some women actually hyper respond and they get hypertrichosis on the 5%. I've seen it.
Well, I think the hypertrichosis is probably because they're touching areas of their body, their face, where they're
or
growing,
it's leaking down.
or they're
I
getting
agree.
peach
They're
fuzz, or they're using too much. But I still
Maybe.
do think 5% is the appropriate dose. I don't think 2% is going to be as effective.
I agree.
But 2% is there if 5% is too strong. I feel more comfortable starting someone on 5%. Also, the other thing that we have to emphasize about all these hair loss medications are it takes time for these things to work, right? You know, it's not like you apply it today and it works tomorrow. It could take 3 or 4 months. So do I want someone on something that might work or something that has a higher likelihood of working? If they have hypertrichosis where you get excessive growth of hair in other areas of your body, let's say peach fuzz, you could always shave that off. Like that is not like a major...
Yeah. I agree.
I think actually I just want to emphasize one other thing. You know, the hypertrichosis issue actually bigger issue when you're taking oral medications, right? Because then you're getting hair underneath your armpits, your groin, around your breasts. Like that is when women are a little more hesitant. I don't know if they're as concerned when it comes to kind of and it would be interesting to bring on a female patient onto our podcast to talk about using these medications and what's their perspective to share with our audience.
Yeah, that would be cool.
Yeah, I think you mentioned something very important, that patients need to be patient, right? So it's going to take at least 3 to 6 months with the Minoxidil, with the Finasteride 6 months to a year. Dutastride's a little bit quicker, actually. You might see results by about 3 months, but you need to be very patient with these things and trust the process.
Now, what do you tell patients in terms of how this works? Because there's no consensus in terms of how Minoxidil actually works to
I just say that
address
it's a
hair
stimulant.
loss.
I just say it tells the hair to grow, and this is, there's so many proposed physiological mechanisms that they talk about that, I've read about, and it just goes through the one ear and literally out the other, for me at least. So I just tell my patients, look, Minoxidil is a hair stimulant. It's going to tell your hair to grow faster, for longer, and thicker. And that's what it does. But it's not going to prevent that pathological process. They say it's due to increased blood flow to the area, angiogenesis.
Sure, it's a vasodilator. So it will increase blood flow to the area. Angiogenesis needs to be proven, I guess. But we know that it shortens telogen phase, which means that your hair will grow longer. A lot of people suffer from when they're experiencing androgenic alopecia, that their hairs won't grow long. So Minoxidil can help that hair grow longer.
It's also important to preface that Minoxidil, back in the 80s or 70s, was originally used as a blood pressure medication. And what they discovered was this side effect of hypertrichosis that you alluded to, Asi. And so at very, very low doses of Minoxidil, we can stimulate hair growth, but we have to be concerned at the same time with the possibility that sometimes people will get heart palpitations, they'll get fluid buildup. These are potential side effects of using both topical and oral Minoxidil, though we don't anticipate that they're going to be massive issues because these are very well-tolerated medications to address hair loss for both men and women.
And I'm glad you said for both topical and oral, because people don't realize that when you apply something topically, it's getting absorbed into your body whether you like it or not. So you apply something to your skin, it's going to get absorbed. Now, when you're applying it to your entire scalp, you don't know how much is being absorbed. I often tell patients that, at least you take a tablet, you know exactly how much you're taking. Whereas if you're going to apply a couple of sprays of Minoxidil all over your scalp, you actually don't know how much of it is getting absorbed into your body.
Eric, you also brought up another good point, which is depending upon how diffuse your hair loss is, you may not want to use topical because it's not going to cover the whole area, or you might be using too much of this. And that's why you have to be on an oral Minoxidil pill, because if you have something called Dupa, where you have diffuse hair loss kind of thinning all over the place, this is not really that effective. It's great for like me where I have some hair loss over here or thinning of the hairline or stuff like that, but it's not going to be really effective to spread this amongst your entire hairline. or your entire scalp, I should say.
And then finally, what dose do you start your patients on for the oral regimen?
So for female patients, what we do is we prescribe 1.25 milligrams on a daily basis, or 2.5 every other day. The reason we do it every day, 1.25, they split the pill in half because you can't get 1.25 in the United States, and taking it every day is just a reminder to be compliant. And for male patients, we put them on 2.5 milligrams, and I feel very comfortable with that. And if I need to increase it, I can, but I find that most patients do very well with 2.5 milligrams if they're male patients.
Yeah, I completely agree. We're a little bit more cautious, mainly because most of our patients are from abroad. So I start everyone off on 1.25 milligrams daily, and then I will push them up after 3 weeks if tolerating well. Yeah, but I mean, either way, most people are very, very comfortable on 2.5 milligrams. And you can even push it up to 5 as well later on.
And it seems like the consensus is really to put them on a DHT blocker mixed with minoxidil, because the mechanisms of action of these two medications is completely different. And the synergy of the two together really gives the bang for the buck in terms of helping to stimulate new hair growth and prevent hair loss.
I mean, there are many things, that you need to look at for hair loss. But if you're treating androgenetic alopecia, I'd say 3 things mainly. It's the 5-alpha reductase inhibitor, it's the minoxidil, and then lifestyle, right? So eating well, having a good body composition, exercising, reducing stress. These are all very, very important because they can speed up your hair loss.
Yeah. And a thought came to me. I'm sure people will be listening. If people listen, they'll say, holy shit, you got to take all these medications and have all these side effects just to keep your hair. And if you're one of those people, I'm going to tell you right now, just shave it then. Because that honestly is the easiest and best thing that you can do. If you can get over your hair loss and shave it, which I have friends who literally rock out with a shaved head and they look fantastic, they feel great, then that's the best thing. Because at the end of the day, if you get a hair transplant, you're going to be in this world for life. You're going to be needing to take medication, most likely. These medications come with side effects, right? Of course, as we discussed, it's the vast majority of people don't suffer with any side effects, but a lot of people do as well. So just to say that if you're feeling that way, shave it. I don't know if you agree with me.
We don't want everyone shaving their scalps, because then we would be out of business and we wouldn't be able to help anyone.
Listen, if they're happy, that's the most important thing.
That's honestly, this. And I'm sure we'll do an episode about this, because Dr. Eric and I were in Turkey for a very long time, and we came across so many, just unethical, unscrupulous providers, more often than not, to be honest. And, Eric and I made a promise to ourselves that, we're getting into this to try help people and to try make them happy. And if we can convince them to shave their hair and they're going to be happy with that, then we've done our job. So I genuinely feel that way.
Rather than get tricked into having a transplant and being left with this weird frontal island and then bald behind that, looks ridiculous.
Yeah. And I guess we're going to get into the nuances of the surgery itself and, the repair, how we do repair cases, etc. on other podcasts, I'm sure. Today, I guess, was just intro the medications. There's not that many, right? I mean, there's really, what else is there, Ross? Did we leave anything out? Minoxidil, finasteride?
Well, there's a lot of other medications to talk about. There's spironolactone. There's other medications that I think...
For women, I agree.
That we're going to dive into. Well, actually, believe it or not, we use spironolactone for male patients as well.
Really? Interesting.
But we'll leave that for another episode. So if you enjoyed what you watched today and you have any questions about the two most popular hair loss medications, finasteride or minoxidil, please leave your questions below. We will make a very concerted effort to address your questions. And if you haven't already, please subscribe to our channel. We are trying to grow our community. This is going to be a phenomenal podcast, and bring on some of the world experts. So we're so excited for you to all come along with us on this journey. And as always, the 3 of us are here to help you address your hair loss.